Hello, everyone. As discussed in the announcement, this week we're going to be covering Chapter 14, which is PCS procedures on the digestive system. In addition to the GI tract, it will also cover procedures on the hepatobiliary system and the pancreas. As you work through these slides and work through this lecture, think about the root operations, the body part values, the approaches, the devices, and qualifiers, but pay a special attention to what is the procedure trying to do? What is the intent? The intent ties back to the root operation, and that's critical to make sure you're working from the correct table. Please have your PCS book open as you follow along. And again, we'll be covering specific tables, and I think the lecture will make more sense to you that way. Okay, let me go to the correct slide. My apologies. And here we are. Okay, so again, if you want to follow along with the slide deck, this is on slide 30 or slide 21, excuse me. Again, the nice thing about PCS is that it's built on logical standardized structures. So if you get the correct root operation, it's usually pretty straightforward. And again, for the most part, we'll be working in tables 0D1 through 0DY. And the root operations you can also see in table 14.1 of your textbook. And this covers all the root operations that are applicable to the GI system. Pay attention. I keep stressing this point because it's very important to the intent of each root operation, whether it's an excision, resection, dilation, drainage, or bypass. The code is going to be based on the correct root operation. And sometimes that can be confusing because you'll read the note and things like an ostomy, you'll see that they're cutting into something, but what is the intent? It's actually a bypass. And again, character 4 of the PCS code identifies the body part. If you're a little bit rusty on your anatomy and physiology, refer to table 14.2 in your textbook. It lists the gastrointestinal body part values, starting with the upper intestinal tract and working their way down. Notice how specific these values are. This breaks the esophagus into an upper, middle, and lower portion and identifies the esophagogastric junction separately. So there's similar diagrams in your code books as well. I think some of you will find these very, very helpful. Continuing on with table 14.2, we now move into the small and lower intestinal tract body part values. Take note how PCS distinguishes between the duodenum, the jejunum, and the ileum and the ileocecal valve as well as the right and left portions of the large intestine. And this level of specificity directly affects the code's accuracy. So even seasoned coders use these types of diagrams to make sure that they are getting the correct body part. Now we're going to talk a little bit about the colon and the rectum, right? And so this covers the body parts that you see here that are also in table 14.2, the cecum, the appendix, the specific segments of the colon, the rectum, the anus, and the anal sphincter. When reviewing the operative reports, you must identify exactly which anatomical segment was treated in order to select the correct PCS value. And the final body part listed in 14.2 is the omentum, the mesentery, and the peritoneum. These structures are commonly involved in procedures such as drainage, excision, and inspection, especially when there's trauma, when there's infection, and so on. The fifth character identifies the approach that's used. And these are listed also in table 14.3. And this could be open, percutaneous, endoscopic, and so on. Make sure that you're clear on these differences between percutaneous endoscopic, and the various natural artificial opening approaches. The approach is defined by how the physician reaches the operative site, not how large the incision is. Character 6 identifies whether a device remains in place after the procedure is completed. You can see a list of these devices in table 14.4, and some of these are mentioned on this slide. This could be drainage devices, radioactive elements monitoring devices, intraluminal stents, and so on. Character 6 identifies if the device is used, and again, in 14.4 will continue to list all these different devices. Now we're on to the seventh character. This is a qualifier, like we've seen before, that specifies an additional attribute of the procedure. This could be something, whether something is allogeneic, xenogenic, zooplastic, and so on. Right? So important to pay attention to the seventh character, and you'll see those summarized on the slide and in table 14.5 as well. And again, more on table 14.5. It lists other qualifiers: ileum, large intestine, cecum. An important thing to think about the seventh character, it's an additional attribute, not necessarily a device, but an additional attribute as per that particular procedure. Now we'll take a look at coding procedures for the hepatobiliary system in the pancreas. These are found in tables 0F1 through 0FY. You can see the root operations in table 14.6, and they're also listed on this slide. Again, key to the root operation, read the entire op report first and figure out what they're trying to achieve. Character 4, as we've seen earlier, is for the body part. This could be the liver, right lobe of the liver, left lobe of the liver, gallbladder, hepatic duct, and so on. So important to read the op report so we get all that fine level of detail for the fourth character. And again, these have a table. They're in table 14.7 in your text: the cystic duct, the common bile duct, the hepatobiliary duct, and so on. And again, now the fifth character, as we've seen before, it's all about the approach. It could be open, percutaneous endoscopic, via natural or artificial opening, and so on. Right? And these are listed in table 14.8, and these are consistent just as you would see in any other approach. The sixth character identifies the device, and the device could be any of these that we see, and you also see them summarized in table 14.9. So this could be drainage, radioactive element monitoring, infusion, and so on. As with any GI procedures, only devices that remain in place after the procedure are coded, right? And again, if you don't have anything from table 14.9, right, none of these apply, then you have the no device option that you would select for the sixth character. The seventh character is a qualifier. And again, as we've seen before, it identifies an additional attribute. whether something is allogeneic, zooplastic, and so on. Table 14.10 lists all the possible qualifiers. You always want to verify the documentation for the diagnostic intent or directional routing before assigning a qualifier. Now we have the seventh character. We almost have an entire code, right? And this would say these additional attributes, whether it's a cystic duct, common bile duct, etc. Now we're going to talk about laparoscopic versus open hernia repairs, right? You have to read the documentation that clearly indicates the approach and whether the mesh and sutures are repaired. If somebody does an open repair through an incision with a sutured repair, it's open, right? Laparoscopic, of course, is exactly what it means. It's done through a scope. It's less invasive. You have smaller incisions. Usually there's three of them, and it allows a thin lighted instrument to be inserted through. And sometimes they use mesh with it, sometimes they don't, but that's what they're talking about with laparoscopic repairs. Herniorrhaphy with a synthetic substitute is used as the root operation of supplement with subterms for the anatomical regions of the general and lower extremities. We could also code this with the root operation of repair with the subterms for the anatomical region for general and lower extremities. If we're using mesh, that's different than a repair. If it's mesh is being used, it's a supplement, right? We're just supporting what's already there. If we're using sutures, we're repairing. And then repair would be the root operation. You may want to review table 1411 in your text for the PCS table 0YU. Closed endoscopic biopsies and excisions are commonly coded using the root operation excision. Please review table 14.12 that shows an example from PCS table 0DB. And remember that a diagnostic biopsy is going to require that diagnostic qualifier. In regards to stoma procedures, a stoma is surgically created that allows GI contents to leave the body. Please read this section in your textbook that explains these procedures under the gastrointestinal stoma procedures. Now we have different types of ostomies, the gastrostomy, colostomy, ileostomy, and loop ileostomy. Each involves altering a route of passage, if you will, for the GI contents. So the root operation is going to be bypass. And this slide kind of describes what they are. This is covered in a finer level of detail in your textbook as well. And again, why are these procedures bypasses? Because we're altering the route of passage of the contents of a tubular body part, right? So for table 0D1, the fourth character is the body part where the ostomy started. The fifth character is the approach. The sixth character is the synthetic or tissue substitute if it's used to create the bypass. And then the seventh character, or qualifier, identifies where the new passage route is directed, whether it's, for example, goes through the skin or what have you. Sometimes they'll do colectomies, right, or colon resections that removes a portion of the large intestine. These can be done either open or through a laparoscope. The root operation is an excision because we're removing a portion of a body part. It could also be a resection if somebody has a total colectomy. You may wish to review Table 14.13 for excision and resection in the GI system. The term anastomosis means forming a connection by surgery between two tubular structures or vessels. And this could be blood vessels or, in our case here, intestines. When an anastomosis is performed as part of the colon resection, the anastomosis is not coded separately, right? So if you do a low anterior resection, you have two ends of the colon, and in between, the middle parts being taken out, right? Even though the title of the operation is this, it's going to be an excision, right? And then you're coding that anastomosis as part of the procedure. So again, it goes back to that guideline that states the procedural steps necessary to reach the operative site or to close the operative site, in this case, including anastomosis of a tubular body part, are not coded separately. And again, some other ones just to close with some thoughts on laparotomy. Laparotomy is the incision into the abdominal cavity. If the laparotomy is done for purposes of opening the cavity, the definitive procedure is in the cavity is coded with the open approach. If the definitive procedure is a biopsy, control of post-op bleeding, what have you, the laparotomy would not be coded separately. It goes back to that same guideline. If the laparotomy is done for exploratory purposes, the root operation would be inspection with an open approach. And that's all I have for you. Thank you so much for watching, and we'll see you online. Bye now.